Hi guys, I hope you're doing well. This is a review video for lecture 55 and 56, which covers lab 6 material. This is on the pyramidal tracts, and as you may recall, pyramidal tracts are for dealing with voluntary motor control of the head and neck region, which is going to be pathway 1, which we'll call the cortical bulbar pathway. And then the second pathway of the pyramidal tract is the cortical spinal pathway, which is going to do voluntary movement of the torso of the body and then the limbs, like arms and legs. All right, so overall what we have is, this is just brief, big picture, we'll get into more details. We have pyramidal cell bodies in the cerebral cortex, and then they're going to send axons down to synapse in the brainstem in the case of the cortical bulbar pathway, and then in the case of the cortical spinal pathway, they're going to go into our spinal cord to innervate synapse in the anterior horn, and then after they've synapsed in the anterior horn, there's going to be a lower motor neuron that is going to go out from there and go to muscle. Okay, so we're going to hear the words upper motor neuron and lower motor neuron. In this diagram right here, we have upper motor neuron, and as we'll see later, the lower motor neurons are going to be what these pathways end in. Right? They synapse on the lower motor neurons. All right, so we're going to start off with this guy, the cortical bulbar pathway. And so this one is all about voluntary control for movements associated with particular cranial nerves that have to do with the face and the neck, right? And so the cortical bulbar pathway, tract one of two of the pyramidal tracts, are the central control for initiating skilled motor, aka voluntary movements associated with cranial nerve 5, which we know is trigeminal. What's the motor innervation of 5? It's the third branch, so the mandibular branch doing mastication. Then we have cranial nerve 7, which is facial expression. And so these are where our upper motor neuron is synapsing at. Then we have the nucleus ambiguus, which is going to contain cranial nerve 9 and 10, dealing with the movement of the pharynx for 9, and then the movement of the pharynx for 10, and larynx for 10, as well as the soft palate for 10. And again, this is all voluntary motor control, is what the cortical bulbar pathway is doing. Then we have 12 is about our tongue movements, right, hypoglossal, and then 9, shoulder and neck movements. All right, so again, it's this blue pathway right here that's starting in the cerebral cortex, and it's going to go down and synapse on each of these cranial nerves that are in the brainstem. All right, so again, starting with what's the origin of this pathway? Well, we have our cell bodies, our pyramidal cell bodies are in the cerebral cortex. Specifically for the cortical bulbar pathway, they're pyramidal cells that are located in the lateral inferior portion of the motor cortex. All right, so here we have some cross sections, but the idea is that, all right, so here's our motor cortex, and we have the motor homunculi that's involved in this. For the cortical bulbar, it's the head and neck portion of the motor homunculi that's part of our motor cortex, right? So the cortical bulbar is about voluntary movement of the face and the neck. So that's this region right here, this lateral and inferior portion of the motor cortex, all right? And so the cell bodies that are making up this pathway, they're located in a couple of different places, but primarily in the primary motor cortex, which is right here. There's also some of them in the motor association area, where we have the supplementary motor area in the premotor cortex, and then we have some in the primary somatosensory cortex, which is right here in the parietal lobe. Okay, so again, we are dealing with our motor homunculi is our new best friend on the primary motor cortex, which is where most of these cell bodies are, these pyramidal cells, and we're dealing with the lower portion of the inferior lateral portion of the motor cortex, because according to our homunculi, again, head and neck, face, head, neck, that is this portion of the motor homunculi. Okay, so primary motor cortex, then we have some premotor cortex as well, and then some primary sensory cortex that are involved, and then again, it's this like lower portion because of the homunculi. All right, so then that's where our cell bodies are located. But now that we have the cell bodies, where are they going to send their axons? Well, they're going to send our axons through the corona radiata and then into the internal capsule, specifically the genu of the internal capsule, and then pass that down into the brainstem to synapse with the cranial nerves. All right, so a little bit more on that, but again, we can already see here's corona radiata. Then you're going to go through the internal capsule, specifically the genu of the internal capsule, and then we're going to end on the cranial nerves. All right, so what are the targets? Well, again, lateral inferior portion of the motor cortex, that's where we're starting. The axons are going through the corona radiata. Corona radiata. Oh, we're dealing with software issues, okay. Into the internal capsule, specifically for cortical bulbar, it's the genu or the knee of the internal capsule, and then we synapse on the cranial nerves. The cranial nerves are going to have the lower motor neurons there, which is the motor neuron that goes and innervates the muscles of the face, for instance. That's the end part of this pathway. All right, so what are we actually synapsing on? So coming down, we have cranial nerve 5, which we know as trigeminal. Then we have the facial right here. Then we have the 9, 10 overall. Then we have 12, and then 11. All right, so in just going from rostral, right, rostral to nostril, caudal to caudal, like hands, caudal's lower, we have mid-pons, and in the mid-pons, we have the first one is our trigeminal nerve, and this is going to receive bilateral innervation, as you can see here, bilateral innervation from the tract coming down from either hemisphere of the brain. It's stronger on the contralateral side. Then we have the caudal pons, so moving further down, and we have the facial nerve. And this one is a little bit tricky because it is bilateral, but only on the top. So here's a diagram from our friend Ninja Nerd. And so the idea is that it's bilateral. So if this is our tract coming in, a cortical bulbar tract, it's bilateral to the portion of the facial nucleus that deals with the top of the face, right? And we can see that here. And then it's unilateral to the contralateral side. It doesn't do this side, so it only does the contralateral side. Okay, so this portion right here would innervate this region of the face, this region of the face, and then the contralateral lower side, but not this side. Okay, and so that's important because if we have a lesion, say here, then it's going to knock out, like this part's going to be weaker, but this side's going to be completely paralyzed because the contralateral side is innervated by the cortical bulbar tract. And then once you get to, so this is the cortical bulbar tract, this region right here, once you get to the nuclei, right, now you're on the facial nuclei here. Notice how the facial nuclei axons, aka these lower motor axons, are ipsilateral. Okay, so the bulbar tract is innervating bilaterally, and then for the top, and then for the bottom, it's innervating contralaterally. Okay, so that's the facial nerve. This is the facial nerve's a special case. The good news is there's not many other special cases. There's just one more. Rostral medulla, so we're going further down. We have the glossopharyngeal nerve, which is doing pharynx. Then we have vagus, pharynx, larynx, and uvula. Then we have mid-medulla, so going down even further. We have the hypoglossal nerve, and so this is the tongue. This is also just like the facial nerve, it's weird. You have bilateral innervation on the top from the cortical bulbar tract, but the bottom is contralateral, right? And so this level of detail we actually don't need to know. We're only told in lecture that the hypoglossal is bilateral but stronger contralaterally, okay? And so the ramifications of this are for lesions. If you have a lesion on, say, this side, you're going to have a tongue deviation towards the opposite side. All right, here's some more detail on that if you want to read it. All right, then we have the final one is the accessory cranial nerve 11. It's just the furthest down because it's starting in the spinal cord, but it receives bilateral. All right, so the only weird ones are we have facial, which is bilateral, except for the bottom part of the facial, which is contralateral. And then we have a bilateral for everything else, but for 5, you have stronger contralateral. And then for the tongue, you have stronger contralateral as well. All right, but it's bilateral. So jaw, and tongue are contralateral, stronger contralateral. All right, so then more on the pathway of the tract itself. So again, cortical bulbar tract, voluntary motor, head, and neck. So we see it's coming down through the arcuate or corona radiata, then it's going into the internal capsule right here, specifically the genu. Then it goes through the midbrain into the pons, and so we see more rostral pons here. Then we get to caudal pons, then we have medulla, and then finally spinal cord for our accessory nerve. All right, so here's like that in detail. All right, so coming down, we have in mid pons our trigeminal motor nuclei of 5. All right, remember it's stronger contralaterally. So that's what this is showing. Then moving from mid pons to caudal pons, right? Caudal is claudal like towards your claws, your hands. And you can see that we have bilateral top, but contralateral bottom. Moving further down, we have rostral medulla, and so in rostral medulla, rostral towards nostril, higher up medulla, we have cranial nerve 9, right? Glossopharyngeal for one of the pharyngeal muscles. And then we have the vagus nerve, also caudal medulla. And then we have, or rostral medulla, and then we have caudal medulla, we have cranial nerve 12. All right, and then past that in the spine, we have cranial nerve 11. All right, and then notice here we have stronger innervation contralaterally, but it's all bilateral with the one exception of the lower part of the face. That's the only part that's not bilateral. All right, but we have 5. Jaw and tongue are stronger contralaterally, but they're still bilateral. Okay, I'm hoping this is helpful to memorize. Okay, so then looking at the cross sections, we start in the cerebral cortex, specifically from our motor homunculi in the motor cortex. Then we go down through the internal capsule, right? So our pyramidal cells here, they send their axons through the internal capsule, specifically the genu of the internal capsule for the face and the neck, which is cortical bulbar. And then before we move on, just very briefly, we were told in lecture that the internal capsule specifically has its blood supplied by this artery called the lateral lenticulostriate artery, aka the LSA. And this is from the middle cerebral artery. Specifically, why is this important? It is the primary supplier for the posterior limb of the internal capsule, but blockage of lateral LSA is a chief cause of stroke, hemiparesis, which is paralysis on one side, hemihypesthesia, which is reduced sense of touch on one side, dysarrhythmia, difficult speaking, and then some abnormal movements. All right, but we've reached the internal capsule. After we've gone to the internal capsule, we keep going. We have the cerebral peduncle here, and we're on the medial part of the cerebral peduncles where the cortical bulbar tract is. Then we go into caudal midbrain. And here we are, notice how we are now separate. Here's the cortical spinal tract, which we'll talk about next. But cortical spinal, which is the other part of the pyramidal tract, and then we have cortical bulbar. Notice how they're next to each other in the rostral midbrain. Well, when you get to caudal midbrain, you are no longer next to each other. Here is the cortical bulbar that we're tracking right now, but cortical spinal was actually over here. Okay, so caudal midbrain, they've split. And then unfortunately for us, this is the last part where we can really find the cortical bulbar tract as an actual tract, like something that you could say that is the cortical bulbar tract. It's part of the cerebral peduncle right here, and we can trace it down, and it's right here next to medial lemniscus. Okay, so now that we have gotten to caudal midbrain and we're past that, next is caudal or rostral pons and then mid pons, but after we have left caudal midbrain, we basically have the cortical bulbar tract is no longer distinct, right? And so we can only tell where their targets are now, unfortunately. And so here we have, this is mid pons, so we have the trigeminal nerve, right? We're going from top to bottom. Mid pons is trigeminal, and again, this is all about the innervation of voluntary movement, right? So do I care that trigeminal is doing sensory innervation of the face? For cortical bulbar, I do not care in the slightest. All right, this is only about voluntary movements. This is mastication, right? And so you're like, okay, but isn't there, like, we have mesencephalic of 5, we have chief of 5, right? And then we have motor of 5. Motor of 5 is where it's at, right? That's what we care about here. So we're going to have bilateral innervation to motor of 5, but we also said it's stronger contralaterally. All right, and then after that, so we're synapsing here, and then the axon after that is from the lower motor neuron. All right, so this is all upper motor. Once we synapse, now we're lower motor neuron. All right. but again, bilateral. Everything is bilateral except for lower face, and you have stronger contralateral for jaw and tongue, right? 5 and 12. All right, so then moving on to caudal pons, we have a facial nucleus of 7, right? And you said this is the one exception. Coming down, again, we can't see the axons. There's no bundle that's cortical bulbar anymore, but we just know where their targets are. So we have the motor nucleus of 7 right here, and again, contralaterally we have top and bottom innervated, and ipsilaterally we only have top and not bottom. Okay, that's facial. Again, we're over here. Caudal pons, facial. All right, moving on, we get mid-medulla. This diagram is messy, I'm so sorry, but you know, we did what we could. So in the notes, this gets a little bit confusing. Ninja Nerd has something different than our notes, and then our note, it's like not cool. But basically what I read was we have the nucleus ambiguous, and the nucleus ambiguous, even according to this, right, like this is the nucleus ambiguous, and according to this diagram, the 9th cranial nerve and the 10th are both part of that, right? But then on this diagram, we have the dorsal motor nucleus of 10 is located right here bilaterally, right? And then here is the nucleus ambiguous. Right? This is mid-medulla. So according to that diagram, 10 should be here as well, but it's back here. So I think it's a little bit of an annoying discrepancy from our notes. But anyways, we know that this is about controlling motor innervation. So we have bilateral innervation of our of 10, right? And then bilateral innervation of 9. And then we also have cranial nerve 12 in this region. So we have stronger 12 is tongue, right? So we have stronger contralaterally, but it is also bilateral. Okay, so we have 12, 12, 10, 10, and then we have nucleus ambiguous, nucleus ambiguous. All right, we go even further because we know that we're still missing one guy, and that's cranial nerve 11, accessory nerve. So we're coming down again. Where's our nice bundle of cortical bulbar? We do not know. It's not nice. It's not a nice bundle. Just spread out, diffuse, I suppose. And so we are coming down. We have bilateral innervation. So here's our accessory nucleus. Here's our accessory nucleus. Bilateral innervation, right there. All right. So not too bad. I hope that's helpful, but you never know. So if we're talking about lesions, we've already kind of covered this quite a bit, but basic premise again is you have cortical bulbar is all bilateral with the exception of the facial nerve, and the facial nerve is bilateral on the top, but contralateral on the bottom, right? So for the left side here, you're going to innervate this part of the face, this part of the face, and then you have this part of the face right here is contralateral. So this would be innervated, this would be innervated, this would not, or this would, and this would not, from the left side of the cortical bulbar. Okay, and then tongue and jaw are bilateral but stronger on the contralateral side. So if you have a lesion to the cortical bulbar on one side, you'll have a say my lesions here on the cortical bulbar side, you're going to have a jaw deviation on the opposite side. Right, that's what we see with this person. And then same thing for the tongue. With your lesions over here, you're going to have tongue deviation towards the opposite side. Okay. All right. Why is that the case? You're going to have your jaw is going to deviate towards it's going to move towards the muscle that can still clench, right? And so then the tongue's going to also move towards the muscle that's still strong. And the logic is a little funky, but I think you just remember, because it's contralateral, the side of the lesion is going to be contralateral to the deviation, right? So the deviation is going to be on the side that's opposite to the lesion on the cortical bulbar tract. Yikes. Okay, so then moving on, we talked about the cortical bulbar tract. Now we have cortical spinal tract. And so again, this is all about, pyramidal tract's all about voluntary movement, right? So cortical bulbar is about face and neck. We covered that from our homunculus. And so like we've already covered this in cortical bulbar. This is cortical bulbar. So now cortical spinal is going to be dealing with the rest of it, right? We got leg, we got butt, we got arm, we got hand, right? And then you got torso, trunk. All right, so that's cortical spinal. Cortical spinal is central control for voluntary movements of the body, the trunk, and then the limbs. All right, and so nice thing is the origin, like we've already covered the basics. It's straightforward. It's basically the same as what we talked about with the cortical bulbar. Cortical spinal is also cerebral cortex. Again, voluntary motor movement. So this is primary motor cortex, which we have located right here. And then you have the premotor cortex and the supplementary motor cortex, which are helping. Premotor cortex integrating sensory movement. Supplementary is helping with planning. And you're like, where does the actual like thinking I want to do an action come from? It's going to come from the frontal cortex. All right, then we have the somatosensory cortex right here, and some of the superior parietal lobe is where we're getting these pyramidal cell bodies from. But again, it's mostly primary motor cortex. And again, you're going to be dealing with the more superior aspect of the primary motor cortex, because you think about our homunculus, and it's the part that's not the head and neck, because that was cortical bulbar. All right, so then here is just, another diagram. Here's our central sulcus, and then here's our frontal lobe, right? And so this is the primary motor cortex in front of it. Here's the premotor cortex. Here's the primary sensory cortex. We have some of the parietal lobe as well, superior parietal lobe, and we're dealing with this region right here, as well as this region right here for the lower limbs. Okay, so in terms of pathway overview, it's pretty straightforward. This one in blue here is cortical bulbar. We don't care about that anymore, but we do care about the cortical spinal. And so cortical spinal is actually going to split. We have the coming down when we get to the medulla, we're going to have pyramidal decussation, and you're going to have splitting where most of your cortical spinal is going to go contralateral, and then some of it is going to stay on the same side, and that's going to be your anterior cortical spinal tract. We were told in lecture to focus on this one, the lateral cortical spinal tract overall. Okay, all right, but the idea is that just like with cortical bulbar, all about voluntary motor movement, and so you're going to get to your target, and the target's going to be in the ventral horn of the spinal cord, which we can see here, right? So you're going to synapse here in the ventral horn of the spinal cord, and then that's going to, that neuron it's synapsing on is the lower motor neuron, and so all of this stuff is the upper motor neuron. Okay, all right, so then more detailed pathway. We have, right, we're starting with our motor cortex, and we're going down through the corona radiata. Then we get to the posterior limb of the internal capsule, and we said that if we go back, hopefully this will load, the lateral lenticulostriate artery, LSA, is supplying the posterior limb of the internal capsule. Why do we care? Because it's the primary place where strokes occur. So then once we are through the posterior limb of the internal capsule, then we're going to go through the cerebral peduncle of the midbrain, then the fascicles of the pons, and then once we get to the medulla, we're going to split and be in our lateral pathway, and then our anterior pathway, which again we're not going to really care about in this class. Okay, so again, starting with our friend the internal capsule. We love the internal capsule because we have the nice basal ganglia here. Then we have the thalamus right here. And so here we have the posterior limb. Here's the genu with our cortical bulbar. And again, you can think, okay, cortical bulbar is like face. So that's genu right there. This is the posterior limb. Okay, so now that we are through the posterior limb, we're going to keep going down. And we are in the rostral midbrain. Once we're in the rostral midbrain, we have the cortical spinal tract as part of this overall cerebral peduncle. Right, so this is the cerebral peduncle, and again we have the cortical bulbars right next to it, and this is the only place that this is the case, other than up here, right, in the internal capsule. Once we get past the midbrain and we're in the caudal midbrain, we now have the cortical bulbars up here, and the cortical spinal is down here. All right, and so notice how we're staying ipsilateral this entire time. We're not going to go contralateral till we get to caudal medulla. All right, so now that we are caudal midbrain, we're in this portion up front right here. We're going to go to our mid pons. Right, we're skipping rostral pons straight to mid pons. And again, it's a nice sleeping section right here in the mid pons. The fascicles is what we call those. This is cortical spinal. Keep going down. Now we're in the mid medulla, and this would be what we call the pyramid of the mid medulla. And when we get to caudal medulla, here we have the desiccation of the pyramids. And so what's going to happen is we've gone ahead and we've come down, and we're going to go ahead and split. So we split and we go to the, and we decussate to the forming lateral cortical spinal tract, which is right here. and then, so this is about 80% of the axons do that, and about like 20% will go stay ipsilaterally and come down as the anterior cortical spinal tract. All right, but most of them are going contralaterally to the lateral cortical spinal tract. In the lateral cortical spinal tract, that's going to come down. Again, this is caudal medulla where this occurs, so the bottom of the medulla. Then you get to the top spinal cord. So in the spinal cord, you're going to go to this section right here, which is the lateral cortical spinal tract, and then you can start to send off, start the synapse with our lower motor neurons. Now that we're in such a place where you could have neurons going off to innervate some muscles. So we're going to be in the anterior or ventral horn right here, and this is going to be where we synapse with our lower motor neurons. So if we're continuing through, we have our, again, lateral cortical spinal tract continuing right here, and then it will synapse in this anterior horn, or ventral, aka ventral horn, with the lower motor neuron. All right. Then if you cared about the anterior spinal tract, cortical spinal tract, which stays ipsilateral, you just see it stay ipsilateral, and it will do the same thing. It can synapse in this anterior horn with the lower motor neuron. Okay, so that's pretty much it. It's not too bad. We have, the next part is talking about lesions, which gets a little bit confusing, but we have blood supply is pretty straightforward. We'll talk about this a little bit more, but we have in the sort of midbrain and pons region, we have this basilar artery comes up, splits, gives us the posterior cerebral artery, and the posterior cerebral artery is going to supply the or cerebral peduncle right there, and this will supply this region. There's not too much to that. As you get further down from midbrain and you get towards medulla, then you have your anterior spinal artery make an appearance, but for the most part it's going to be the basilar artery that we're concerned with when we talk about lesions, and basilar is giving us posterior cerebral artery. All right, so we talked about cortical bulbar, cortical spinal, the tract themselves that we care about are all upper motor neurons, but when they finally synapse, you get to lower motor neurons. So what if you have damage to an upper motor neuron? If you have damage to the upper motor neuron, what happens is, and here we're talking about cortical spinal tract in particular, but you can have increased deep tendon reflexes. So basically a greater than normal response after tapping a tendon using a reflex hammer, and loss of the cremasteric reflex. So basically if you touch the superior medial part of the thigh, right, upper inner thigh, then you have the testicles will pull upwards. So loss of the testicle reflex, increased deep tendon reflex, right? So increased reflex of like kick outwards, perhaps. Loss of abdominal reflexes. So when the umbilicus moves toward the site of the stimulus after being firmly stripped by the skin of the abdomen around the umbilicus. Clonus, which is a series of repetitive abnormal reflex movement of the foot after sudden dorsiflexion. Spastic paralysis, which is muscle control disorder characterized by tight or stiff muscles or inability to control those muscles. Basically, the theory is that hyperinnervation is a phenomenon of sprouting synaptic plasticity that occurs in the non-lesioned fibers innervating the deinnervated spinal neurons. So, hypertonicity, increased muscle tone, clasp knife response, Golgi tendon reflex with a rapid decrease in resistance when attempting to extend or flex a joint, exhibiting increased resistance. Positive Babinski sign, which is basically begins when hours to days after an injury. If you stroke the lateral sole, toes are going to flare. Oops, which we can see here. So if you stroke here, then the toes will flare upwards. And a positive sign is normally present in infants, but not in adults. And so if you have damage to the cortical spinal pathway, doing this and having them splay their toes would be a positive sign. Then we have the Hoffman sign, basically tapping the nail or flicking the terminal phalanx of the third or fourth finger. A positive sign is seen with flexion or adduction of the terminal phalanx of the thumb. All right, so if you flick this guy, then seeing that they might pinch together or bring the thumb in would be the Hoffman sign. All right, so as we said, upper motor neurons are represented by this diagram. When they go ahead and they synapse at their targets, well, what they're synapsing on is the lower motor neuron. And so, as we said, we're dealing with lesions and trying to clinically map out where something has gone wrong. And it's very useful to know that, for instance, cortical bulbar is bilateral except for lower face, right? And cortical spinal is, primarily contralateral overall. All right, and so lower motor neurons are going directly to the muscle from either the cranial nerves, where their bodies are, or in the anterior, aka ventral horn of the spinal cord. Okay, so signs of upper motor neuron damage. We kind of just talked about this, but increased deep tendon reflex, right? Get hit with the hammer, kick out really hard. Loss of the testicle reflex, loss of the abdominal reflex, clonus, self-sustained oscillating stretch reflex when the clinician briefly stretches a hyperreflective muscle, causing rhythmic series of muscle contractions, spastic paralysis, hypertonia, which increased muscle tone, the clasp knife response, rapid decrease in resistance when attempting to flex a joint, Babinski sign. So clasp knife response, I suppose like clasping a knife, you would rapidly let go because you've hurt yourself. So rapid decrease in resistance when attempting to flex a joint, just like if you had grabbed a knife. All right, then you have Hoffman sign, again, flexion of the thumb if you flick the end of the third or fourth finger. And then for lower motor neuron damage, basically decreased reflexes, muscle fasciculation, muscle atrophy, flaccid paralysis, and then hypertonia. All right, so so what is clonus? Involuntary rhythmic body muscle contraction, usually evoked at ankle joint. What is clasp knife? Rapid decrease in muscle resistance, flexed form collapses into extension. Okay, so here, this is just from the lab. I thought it was good to take a look at, but so upper motor neurons, cortical bulbar synapse on cranial motor neurons, which we're familiar with. So bilateral cortical bulbar to 5. 5 is one of our exceptions, right? It's the jaw. So if you have a lesion, it's going to be contralateral to lesion. Same thing with the tongue, it's going to be contralateral. And then cranial nerve, facial nerve, lower paralysis is contralateral. For 10, you have bilateral innervation, so no visual effects. Bilateral innervation of 11, no visual effect. So it's really only the jaw, the tongue, and then the face ones that you need to know for cortical bulbar. For lower motor neurons, right, that's after the cortical bulbar tract, you're going to have ipsilateral, and then for cranial nerve 10, vagus, you'll have contralateral deviation of the uvula. All right, so contralateral of our uvula in the back of the mouth. All right, so I think we're just about done. We have hemiaplasia is our very final one. And so these are all just syndromes, and so we spent a long time on this in lecture, but it's really not too bad. So hemiaplasia is paralysis on one side of the body, and the basic idea is that you have cortical spinal tract lesions with the following cranial nerve lesions. And so basically, if you look at the cross sections, which we will in just a second, and you have a lesion in a certain area, unfortunately, like all of this stuff is kind of packed together. So for each one of these particular syndromes, unfortunately, if you have a lesion here, for instance, you're also going to get the ocular motor axons, in addition to what's right here, which is, of course, the cortical bulbar tract, and then you have cortical spinal tract right there, right? And so it is unfortunate, but we have 1, 2, 3, 4, 5 of these that we need to know. The first is cranial nerve 3. The nice thing is they get kind of labeled based on top to bottom. So cranial nerve 3 being the most rostral of these is the superior alternating hemiplasia. Hemiplasia is paralysis on one side of the body. So superior alternating hemiplasia, also called Weber syndrome, is when you have a lesion here, right? So here we're midbrain. We have cranial nerve 3 right here. It's sending its axons down, and for lesions right here, it's going to get our axons of 3, and it's going to get our cortical bulbar, which is right here. Okay, and so unfortunately, if you get our cortical bulbar, this would be a case of basically getting upper motor neuron, cortical spinal, cortical bulbar, so spastic hemi paralysis, hyperactive deep tendon reflex. Again, this is just cortical spinal, clonus. Again, what is clonus? Is like Clonus is involuntary rhythmic muscle contraction, usually evoked at an ankle joint. Okay. Positive Babinski reflex, right? That's the extension of your toes. Lower facial paralysis, that's the face. And then for the ocular motor neuron, it's ipsilateral, external, stratus, so cross-eyed, and then all these are like eye drooping, double vision, and then pupil dilation. Direct light reflex loss, consensual light reflex loss. So Weber syndrome is your eyes are jacked up and you have pyramidal tract issues. And so what's causing it is thrombosis blockage of the basilar artery. So we go back here, we have the basilar artery for midbrain, right? And so here we have the ocular motor nerve, and here's the ocular motor axon coming out. So if we have a lesion right here, and this region is being supplied by the basilar artery, and the posterior cerebral artery, so blockage here is going to say, well, these guys are going to die. If those guys die, then you might have Weber syndrome, which is superior alternating hemiplasia, jacked up eyes, and the upper motor neuron issues that you have, right? Spasticity, hyperactive deep tendon reflex, clonus, Babinski, lower facial paralysis. All right, then you have trigeminal alternating hyperplasia or hemiplasia. So again, hemiplasia is paralysis of one side. And so here we are, looks like we are in the pons region. So if you have a lesion right here, unfortunately, you're getting this. And we're familiar with the fascicles of the pons as holding our cortical spinal. So if you get your cortical spinal, and then you're also getting cranial nerve 5 coming out, you're going to have something wrong with the jaw, we know. So you're not only getting spinal issues, which are going to be pyramidal tract, spastic, hyperactive deep tendon, clonus, loss of cutaneous reflexes, right? That's cremasteric, the testicles one, and then Babinski, your feet. Then you have cranial nerve 5, right? And so 5 is here, but these are the axons of 5. So if you're doing axons of 5, then that's going to be dealing with ipsilateral stuff, right? Because we're not talking about bulbar. Bulbar's coming down, synapsing. If we got bulbar, then we might be in a contralateral or a bilateral situation. All right, but it's ipsilateral, so you're going to have deviation towards the side of the lesion. If you had gotten the bulbar, cortical bulbar tract, the lesion would be opposite, contralateral to the deviation of the jaw. All right, hyperacusis is sensitivity to sound, but trigeminal alternating hemiplasia is 5 and the pyramidal tract. Okay, so 5, trigeminal alternating hemiplasia. All right, what causes this? Again, basilar artery getting blocked. All right, and then you can think, well, 5 is located right here, so basal artery, and yeah, so we have 5 sending its axons here, and we have a lesion right here that's getting, unfortunately, a cortical spinal and cranial nerve 5 axons. All right, but it's trigeminal alternating hemiplasia. All right, then we have middle alternating hemiplasia, acofoval syndrome. This is cranial nerve 6 and the pyramidal tract. And so cranial nerve 6 is right here. 6 is abducens, and that's doing lateral rectus, right? And so lateral rectus, if you have something wrong with the lateral rectus muscle, then you're going to have strabismus, which is cross-eyed. You could also have diplopia, double vision. But since our lesions right here, we got a fascicle in the pons, and so we got cortical spinal tract, we got all of our usual cortical spinal tract issues, and then our basilar artery, just like up here for all the other ones. All right, but that's middle alternating hemiplasia. That's cranial nerve 6 in the pyramidal tract. Then you have Millard Gubler, and this is 6 and 7. So 6 we already talked about, but here we still have more pons. But if you're right here and compare it to this, so the lesion doesn't extend quite as far, right? This next one's more like that. If we extend further out, not only are we getting abducens, axons right here, but we're also getting axons of the facial nerve. And so axons of the facial nerve, well, we're not getting cortical bulbar, we're getting the axons of the facial nerve, so this is going to be ipsilateral issues, right? And so you could have an entire side of the face, top and bottom, are going to be paralyzed. All right, and then hyperacusis, sensitivity to sound. All right, so that was our Millard Gubler, which is face and lateral rectus. And then our final one is inferior alternating hemiplasia, which is 12 in the pyramidal tract. And so 12 is located right here, and its axon's going to come down here, and here's the pyramidal tract with the cortical spinal. So if you get that, then you're going to get 12 and the cortical spinal. Here's all their cortical spinal issues. What would cause this? Well, we're further down. This is medulla, right? And so if we're further down here, now we start to have the anterior spinal artery. So if you have a blockage to the anterior spinal artery, then you could get 12, and so our lesion is like right here. We got pyramidal tract, and so we got axon the 12, and we got the pyramidal tract, the cortical spinal. All right, so that's it. That was maybe helpful, super long, and I hope you guys are doing well. So good luck, guys. I'll see you next time.